Now, the following radiograph of a 78-year-old male with difficulty in swallowing with on and off pain. He also experienced weight loss during this period. What is the most probable diagnosis with the help of the following radiograph? So the options are rolling hernia, granulation tissue, epiphrenic hernia, sliding hiatus hernia. Now, if you see, this is what this is. This radiograph. This is gastroesophageal junction. Clear? And this is what this is fundus of stomach. Now, fundus of stomach has come into the mediastinum. That means it is what? It is rolling type of or paraesophageal type of hiatus hernia. Now, let us have a look on different types of hiatus hernias. Then we will come on to the options. So, we classify the hiatus hernias into 4 types. We have type 1, also called as sliding type of hiatus hernia. Type 2 is paraesophageal type of hiatus hernia. Type 3 is mixed, that is it having both components of sliding as well as rolling type. Whereas type 4 is paraesophageal complex type of hernia. In this, there can be herniation of a complete organ or some other organ can herniate from the abdominal cavity into the thorax. Now, type 1 is sliding hiatus hernia. In this, can you see the gastroesophageal junction? This is gastroesophageal junction. It has come into the mediastinum. Normally, gastroesophageal junction is present here, but it has come into the mediastinum. So, herniation of gastroesophageal junction into the mediastinum is what? It is sliding, because there is sliding of the gastroesophageal junction upwards. So, this is sliding type of hiatus hernia. After that, now these sliding type of hiatus hernia, these patients will complain of what? The most common symptom will be gastroesophageal reflux disease. So the most common symptom that this patient will present with will be what? It will be gastroesophageal reflux. Again, can you see? This is what? This is hiatus, and the gastroesophageal junction has slided upwards. Now this is barium swallow of the patient. It has slided upwards into the mediastinum. So this will be sliding hiatus hernia. Again, this is the endoscopic image. In type 2, we have paraesophageal hernia. In this, the gastroesophageal junction lies in its normal location, but there is herniation of what? Herniation of fundus part of the stomach upwards. So this is the normal location of gastroesophageal junction. It is at its normal location, whereas the fundus has moved upwards into the thoracic cavity. So it will cause what? It will cause compression of the esophagus. There can be volvulus at this site, and the patient may have epigastric pain. There can be dysphagia, and there can also be lung compromise can also be there. So these patients will present with dysphagia, epigastric pain, and sometimes there can be lung compromise also. Clear? Again, this is what? This is the barium swallow. It is showing what? You see, this is normal gastroesophageal junction, and the gastric fundus has herniated through this upwards into the thoracic cavity. Now in type 3, it is mixed. It has both components. In this, you will find both the gastroesophageal junction, it has slided upwards, whereas there is also the fundus has also slided upwards. So there is both gastroesophageal junction upwards and herniated fundus upwards into the esophagus. And these type of patients will have symptoms of both type 1 and type 2. That is, there will be both symptoms of gastroesophageal reflux, epigastric pain, dysphagia, and symptoms of lung compromise. Now type 4 is paraesophageal. In this, you can see there is herniation of complete stomach. Complete stomach is in this, you can see on this, there is herniation of complete stomach into the thoracic cavity. So it is what? It is type 4 paraesophageal hernia, also called as complex type of hernia. So, in which the abdominal organs, they slide into the thoracic cavity, and there can be respiratory compromise, there can be dysphagia, the patient will have dyspnea also. So these are the important types of hiatus hernia. So in this, I told you this is fundus of the stomach, this is gastroesophageal junction. Now you tell me, what is this type? This is paraesophageal type. Paraesophageal type is also called as rolling type of hernia. It is type 2. It is type 2. Type 2 hiatus hernia, also called as rolling type of hiatus hernia. Now, question is asked in the exam, which is the most common type of hiatus hernia? It is what? It is sliding type of hiatus hernia. Important one-liner, most common type of hiatus hernia. It is sliding. It is not rolling. It is sliding type or type 1. Clear? After that, next we have a 50-year-old lady with colicky abdominal pain and fever had multiple gallbladder calculi measuring 1.5 centimeters. There is no dilation of the CBD noted. She was scheduled for laparoscopic cholecystectomy. Which of the following is not a feature of minimal access surgery? Clear? So minimal access surgery. Now let us try to have a look on the various advantages and disadvantages of minimal access surgery. If you talk about the laparoscopic surgeries, the 7 degrees of freedom, they are well developed and proven. Laparoscopic surgeries, they are less traumatic. There is direct visualization on the this camera on the screen. The procedure times, there is decreased inpatient stay, decreased patient recovery time, and increased patient satisfaction in laparoscopic surgery. Whereas the disadvantages are the learning curve is longer. The 4 degrees of freedom, they are less. 2D image picture, it shows 2D image picture. Then we have tremor amplified. Clear, though there can be tremors, and touch or tactile sensations, they are decreased. Now in this case, if you see the options, so in laparoscopic surgeries, improved vision is there, yes. Decreased pain is there, yes. Good tactile sense, no, because we are not directly handling the organs. The organs, they are being handled with the help of laparoscopic instruments. So the tactile feedback that the surgeon receives is very less. So the tactile sense is not good. Decreased wound size, it is also true. So the which is not a feature of minimal access surgery. It is what it is. The correct answer is option C. A 32-year-old man comes to the physician because of a 4-week history of colicky abdominal pain and diarrhea. He has bowel movements 10 to 12 times daily. The stool contains blood and mucus. He constantly has the urge to defecate. His vital signs are within normal limits. Examination of the abdomen shows diffuse tenderness to palpation. The serum concentration of C-reactive protein is 20 milligrams per liter. A colonoscopy shows a bleeding ulcerated rectal mucosa with severe pseudopolyps. Which of the following is this patient at greatest risk of developing? So if you see the clinical scenario, the patient is suffering from inflammatory bowel disease, which is what it is, ulcerative colitis. Ulcerative colitis. Now you see in ulcerative colitis, what is there? The rectum is involved. Clear? Pseudopolyps, they are present in ulcerative colitis. Where in Crohn's disease, pseudopolyps are not there. Rectum is usually not involved. Rectal sparing occurs in Crohn's disease. So which of the following, the patients of ulcerative colitis, they have increased risk of developing colorectal carcinoma. So the correct answer is colorectal malignancies. Now let us have a look on important features of Crohn's disease and ulcerative colitis. This is very important topic, frequently asked in exam. So we have, if we talk about Crohn's disease, the involvement is non-continuous and skip lesions, they are seen. So can you see in this image, this is Crohn's disease, skip lesions, they are present. Skip lesions are present, whereas ulcerative colitis, there is continuous involvement. If we talk about the site, the Crohn's disease can involve any part of the GIT extending from oral cavity up to the rectum. So it can involve any part of the GIT. Common sites, they are terminal ileum, and which is the most common site which is involved in Crohn's disease? It is terminal ileum. So ulcerative colitis, the most common site is rectum, and it ascends upwards involving sigmoid, descending colon, then transverse colon. Clear? Sometimes in some conditions, ileum can also be involved in ulcerative colitis, and that is termed as backwash ileitis. So involvement of ileum in ulcerative colitis is termed as backwash ileitis. After that, if you talk about the ulcers in Crohn's disease, they are serpiginous ulcers, whereas in ulcerative colitis, we have long ulcers which are broad-based. Pseudopolyps, they are rare in Crohn's disease but are a common feature of ulcerative colitis. After that, fibrosis is common in Crohn's disease but rare in ulcerative colitis. Fissures and fistula, they are common in Crohn's disease, whereas they are not seen in ulcerative colitis. If we talk about the microscopic features, the inflammation in Crohn's disease is what? It is transmural because it involves whole of the wall, this thickness, whole of the wall thickness of the bowel. So it is transmural inflammation, whereas in ulcerative colitis, it mostly involves mucosa and superficial mucosa it is involved. Granulomas, they are seen. And what type of granulomas? These are basically non-caseating granulomas. So non-caseating granulomas, they are a feature of Crohn's disease, whereas granulomas, they are not seen in ulcerative colitis. Okay. Muscularis propria, on microscopy, it shows inflammatory cells in Crohn's disease, Whereas, as you know, this muscularis mucosa, it is spared in ulcerative colitis. It only involves the mucosa and submucosa. So and there is a variety which is termed as toxic megacolon. In this, the complete wall of the colon it is involved. So it is termed as toxic megacolon. In this, the muscularis mucosa it is also involved. Fibrosis is a feature of Crohn's disease, whereas it is absent in ulcerative colitis. So these were important differentiating points frequently asked in exam, and you should try to remember them. So in this case, ulcerative colitis has high risk of developing colorectal malignancy. So the correct answer is A. A 30-year-old presented with slight nausea and vomiting, pruritus, slight jaundice, dark urine, a fairly affected overall condition, and a positive blood test for acute hepatitis B infection. Her laboratory workup showed a progressive hepatic failure and liver transplantation was considered. She had all of the following are considered as King's College selection criteria for liver transplantation in acute liver failure, except now you see King's College selection criteria, it is used in what? It is used in transplantation, for liver transplantation in acute liver failure patients, and this acute liver failure can be due to acetaminophen or paracetamol toxicity patients, or in non-paracetamol toxicity patients also. So in short, this criteria it is used for liver transplantation in acute liver failure patients. Liver transplantation in acute liver failure patients. So let us try to have a look on this criteria. So we have acute liver failure due to paracetamol poisoning. Then we have acute liver failure which is not due to paracetamol. Now in the first we have, if arterial pH is less than 7.3 after resuscitation and after more than 24 hours since ingestion, lactate levels more than 3 millimoles per liter, or the three following criteria: hepatic encephalopathy more than grade 3, serum creatinine levels more than 300 micromoles per liter, and INR of more than 6.5. So these criteria they are included in acute liver failure due to paracetamol poisoning. Whereas acute liver failure which is not due to paracetamol poisoning, we have the INR of the patient it is more than 6.5, or 3 out of 5 of the following criteria. So we have etiology, if it is indeterminate etiology with a hepatitis or drug-induced hepatitis, age less than 10 years or more than 40 years, interval jaundice, that is the time interval from the development of jaundice to encephalopathy, it should be more than 7 days, bilirubin more than 300 micromoles per liter, and INR of more than 3.5. So this is King's College criteria. Another important criteria which is also asked in the exam, it is what? It is Bijon-Paul-Brose criteria, also called as Clichy's criteria. It includes the development of confusion or coma in the patient, or if the hepatic encephalopathy is stage 3 or stage 4. Then factor 5 is less than 20% of the normal if age is less than 30 years, or factor 5 is less than 30% if age is more than 30 years. So in this case, it is asking about the King's College criteria. So I told you age more than 40 years. Yes, it is a criteria. Serum creatinine more than 300. It is not a criteria. Now this question, it is talking about acute hepatitis B infection causing acute liver failure. So it will come into the classification of non-paracetamol acute liver failure. So in this you see there is serum creatinine. It is not implicated in this, whereas it is implicated in failure due to paracetamol, and again its level should be more than 300, but in the question it is written more than 100, so this is wrong. More than 7 days of jaundice before encephalopathy, I told you the interval between jaundice and encephalopathy should be more than 7 days. This is correct. This is correct statement. Bilirubin more than 300 micromole per liter. Yes, this is also correct. So bilirubin more than 300 micromole per liter. This is again correct. So what is wrong in this is serum creatinine more than 100. This is wrong statement. A 70-year-old man is brought to the physician by his son because of gradually progressive yellowish discoloration of his skin and generalized pruritus for the past 2 weeks. During this period, his appetite has decreased and he has had a 6.5 kg weight loss. He reports that his stool appears pale and his urine is very dark. 3 years ago, he had an episode of acute upper abdominal pain that was treated with IV fluids, NSAIDs, and dietary modification. He has stopped drinking alcohol since then. He used to drink 1 to 2 beers daily for 40 years. So the patient is a known case of alcoholic. He has smoked a pack of cigarettes daily for the past 50 years, known smoker. His vital signs are within normal limits. Physical examination shows yellowing of conjunctiva and skin, that is, the patient is suffering from jaundice also. The abdomen is soft, non-tender. A soft cystic mass is palpated in the right upper quadrant. Serum studies show the bilirubin, it is increased. Direct bilirubin is increased, that means it is a case of obstructive surgical jaundice. Alkaline phosphatase is also increased. AST, ALT, they are within normal limits. So abdominal ultrasonography shows an anechoic cystic mass in the subhepatic region and dilatation of the intra and extrahepatic bile ducts. Which of the following is the most likely diagnosis? So you see, after seeing the clinical scenario, this is a case of pancreatic adenocarcinoma. So this is a case of pancreatic head adenocarcinoma. And why not acute cholangitis? You see, acute cholangitis, the patients, they have features of Charcot-Stripe, as it is intermittent jaundice, intermittent pain, intermittent fever. Now, in this clinical scenario, Charcot-Stripe is not present, so you can rule out acute cholangitis. Clear? Now, choledocholithiasis, again, it is stone in the CBD. It will cause obstructive jaundice, but again, it will call colicky type of abdominal pain. Now, you see, in choledocholithiasis, or again, this history of smoke intake, history of smoking, history of alcohol intake, and gradually progressive jaundice. It is a feature of adenocarcinoma. Again, there is in choledocholithiasis, there will be episodic pain, but in this, the patient is asymptomatic as the abdomen is soft and non-tender. A cystic mass is palpated in the right upper quadrant, and anechoic lesion ultrasonography showing an anechoic cystic mass in the subhepatic region. Okay? Whereas in choledocholithiasis, it will not show. In the choledocholithiasis means stone, so it will show calcified mass. So it will again be incorrect. Alcoholic hepatitis, in alcoholic hepatitis, the liver enzymes will be deranged. So in this case, you can see AST, ALT, they are normal. Clear? So this again does not go towards the diagnosis. Now, pancreatic adenocarcinoma, what are the positive points which are in favor of this? Smoking, alcohol, they are risk factors for pancreatic adenocarcinoma. After that, decrease in appetite, as is written in the question, and weight loss, these are features of malignancy. Clear? So this again, obstruction of the bile duct, so which is clear due by the fact that the bilirubin and direct bilirubin, they are raised. So this is a case of obstructive jaundice with weight loss, with anorexia, loss of appetite, with increased gradually progressive yellowish discoloration of the skin. So it goes towards the diagnosis of pancreatic adenocarcinoma. And please remember, it is the most common type of pancreatic cancer. So which is the most common type of pancreatic cancer? It is pancreatic ductal adenocarcinoma. Clear? After that, next we have true about Sievert classification are. Now, what is Sievert classification? It is, this classification is used in gastroesophageal tumors. So GE junction tumors, gastroesophageal junction tumors. Now, before coming on to the options, let us try to have a look on this classification. Now we have Sievert type 1. This is what Sievert type 1, it involves, this is gastroesophageal junction. So if the tumor is located 1 centimeter above and 2 centimeter below the GE junction, it is called as Sievert 2. If the tumor is located 1 centimeter above, between 1 centimeter above and 5 up to 5 centimeter of the esophagus, it is Sievert type 1. So in Sievert type 1, what is the recommended surgical option? We go for transthoracic esophagectomy. Clear? Now, after that, Sievert type 2, it involves within 1 centimeter above and 2 centimeter below the gastroesophageal junction. So in this, the treatment will depend on the esophageal invasion. So if esophageal invasion, it is more than 3 centimeters or equal to 3 centimeters, we will go for Ivor left esophagectomy with upper middle mediastinal lymphadenectomy. And if esophageal invasion is less than 3 centimeters, now again, if in esophageal invasion is less than 3 centimeters, but gastric invasion is less than, because you know it is involving Sievert type 2 is involving esophagus as well as what, the stomach. So if esophageal invasion is less than 3 centimeter but gastric invasion is less than 1/3 of the stomach, we will go for extended proximal transhiatal gastrectomy with mediastinal lymphadenectomy. But if gastric invasion is more than or equal to 1/3 of the stomach, we will go for extended total transhiatal gastrectomy along with lower mediastinal lymphadenectomy. Clear? After that, in severe type 3, what is there? This tumor, it is beyond 2 centimeter into the stomach up to 5 centimeters of the stomach. So if the location of tumor is beyond 2 centimeters from the gastroesophageal junction up to 5 centimeters of the distal stomach, so we have type 3. In this, the treatment option is none other than extended total gastrectomy. So we have to go for total gastrectomy. So in this, you don't need to go into the treatment details. What has been asked earlier in the exam and what is repeatedly asked in the exam is just the classification, thus the C word classification. So you should try to know the C word classification. So type 1 is what? 1 centimeter above up to 5 centimeter of esophagus. Type 2 is between this 1 centimeter and 2 centimeter below the gastroesophageal junction. And type 3 is below 2 centimeter up to 5 centimeters of the stomach. So in this, let us try to have a look on the options. Type 1 tumors are located between 2 and 5 centimeter quadral to G junction. This statement is wrong. Type 2 tumors have a tumor center located from 1 centimeter above and the G junction to 2 centimeter below it. Yes, this is true. I told you type 2 is 1 centimeter above to 2 centimeter below. Correct. Then type 3 tumors are tumors of distal esophagus within 1 to 5 centimeters above the G junction. This is false. So the correct answer in this case is answer B. Clear? After that, we have a 69-year-old man is admitted to the emergency department with an acute upper GI hemorrhage following a bout of repeated vomiting. Fiber optic gastroscopy reveals 3 linear mucosal tears at the G junction. What is the diagnosis? So linear mucosal tears at the G junction should clinch the diagnosis towards Mallory-Weiss tears. Clear? Now, Mallory-Weiss tears, these are basically the longitudinal tears occur at the G junction and it involves the mucosa only. Though these are basically the mucosal tears which are occurring. So let us have a look on this Mallory-Weiss tears. These are commonly associated with what? Alcohol abuse. The most common association, up to 70% of the cases, they are associated with alcohol abuse. Now, why it is so? Because you see the patients who are chronic alcoholic, they have repeated bouts of vomiting. So due to this repeated eructations and vomiting, there is what? There is tear in the mucosa and that is called as Mallory-Weiss tears. Again, bulimia nervosa, these patients, they again have the they again do repeated vomitings. So these patients, they also develop it. Then due to repeated coughing in patients of hiatus hernia and food poisoning. So these are the risk factors which are associated with this Mallory-Weiss tears. Now in this case, if you see, these are basically superficial longitudinal mucosal tear in the esophageal mucosa. So this is very important. So in Mallory-Weiss tear, it involves only mucosa, whereas in Borhev syndrome, which is spontaneous esophageal perforation, whole thickness of the esophagus it is involved. It involves whole of the thickness, whereas Mallory-Weiss only involves mucosa. After that, it may bleed if tear reaches up to the submucosal vessels, and the patient will present with upper GI bleeding. The patient will have hematemesis, the coffee ground appearance or bright red color of the blood, it may be there, or these patients may have melena also. Clear? Now, after that, if we talk about the diagnosis, so endoscopy, it is an investigation of choice. Clear? And you can go for esophagogastroduodenoscopy also. Clear? After that, what is the management? It is self-limiting in most of the cases and no treatment is required. But in case if there is active bleeding, it can be treated endoscopically using epinephrine injection, coaptal coagulation, band ligation, or sometimes hemoclipping of the involved vessel. It can be done. Hemoclipping is done by what? Using endoscopy, we apply under vision with the help of endoscope. Clipping of that vessel is done in order to control the bleeding. So again, one important syndrome which is frequently asked in exam, it is Borhev syndrome. What is Borhev syndrome? It is again an important cause of upper GI bleed in which there is spontaneous esophageal perforation. Clear? Now these patients have a triad which is termed as Mackler's triad. Mackler's triad, it includes what? It includes epigastric pain, then subcutaneous emphysema, and vomiting. So this is Mackler's triad which is present in Borhev syndrome. Again, another important point regarding Borrelia syndrome, I told you this perforation in the esophagus. It involves complete thickness of the wall of esophagus, whereas in miliary VSTS only mucosa is involved. So the correct answer is D. Now, a 45-year-old female patient who presented with a sudden severe headache underwent a CT brain scan and was diagnosed to have a subarachnoid hemorrhage. The therapy for her includes all except, now you see, subarachnoid hemorrhage, it is the most common type of intracranial hemorrhage, and the patient, they present with severe sudden onset headache, and that may be the worst experience that the patient may feel of that headache. So subarachnoid hemorrhage, the patient have sudden onset severe type of headache. Clear? Now in this, the therapy, we have 3H therapy, which is used in subarachnoid hemorrhage. It comprises of what? We have hypertension, hypervolemia, and hemodilution. So these 3H therapy, it is included in subarachnoid hemorrhage, whereas hypothermia is not included. Now let us have a look on this triple H therapy. So we have, it is a medical treatment used to prevent the vasospasm. You see, after aneurysmal hemorrhage, what is the most common cause of subarachnoid hemorrhage? It is aneurysmal hemorrhage due to rupture of Barry aneurysm in the circle of Willis. So after that, what happens when there is rupture? These vessels, they go into vasospasm, and the cerebral perfusion, it is impaired due to this vasospasm. Now, what is our aim? Now we have to maintain the normal cerebral perfusion. So that is why we have to do 3H therapy. The patient is to be maintained at a higher BP, so hypertension, hypervolemia, and hemodilution is to be maintained, so that the vasospasm induced cerebral ischemia or cerebral trauma is not there. So hypertension in general, we have to maintain the systolic BP above 150, though some patients will require a higher systolic BP to prevent vasospasm. So it can be maintained, it has to be maintained to more than 150 systolic BP, and mean arterial pressure has to be maintained to more than 100. The use of vasopressors will most likely be needed to maintain this systolic BP. Clear? An arterial line is absolutely necessary to maintain it. In hypervolemia, the fluid volume should be optimized with CVP of more than, in between 8 to 12, it has to be maintained, and higher if vented due to the artificial elevation in pressure due to mechanical ventilation. So hypervolemia is to be maintained again in order to maintain the cerebral perfusion pressure. Then hemodilution, it goes hand in hand with hypervolemia to decrease the viscosity, so that adequate amount of blood is present in the brain, and it facilitates the blood flow through the cerebral vasculature. So these are some important points regarding the triple H therapy, which is done in cases of subarachnoid hemorrhage. So always remember, the risk of vasospasm is about 4 to 12 days after the initial hemorrhage. So vigilance and careful neurological assessment, they are vital. So these are very, very important. Now, what is the pathophysiology of delayed cerebral ischemia of subarachnoid hemorrhage? What happens when there is subarachnoid hemorrhage? It leads to what? This hemorrhage, it leads to the breakdown of blood-brain barrier. After that, there occurs the microthrombosis and vasoconstriction in the surrounding area. Now, this thrombus and vasoconstriction can lead to ischemia of that affected part of the brain. Now, in order to avoid this ischemia and this vasoconstriction, we have to give this triple H therapy. So this is very, very important. In this, the hypothermia is not there, so the therapy for include all. This is included, this is included, this is included, but hypothermia is not included. So the correct answer is D. A 28-year-old male was brought to the emergency with sudden onset of sharp chest pain with sweating and breathlessness. It started after an inconsolable cough, which leads to increased severity leading to pain. On asking the patient, he had no such past history with no underlying disorders but consumes alcohol occasionally. From the given scenario, what is the most likely diagnosis? So this patient has sudden onset chest pain, there is sweating, breathlessness, and it started after cough. So, and there is increased severity of the pain. So it goes towards the diagnosis of what? Pneumothorax. Pneumothorax, and it is basically what? It is spontaneous pneumothorax. Spontaneous pneumothorax. This spontaneous pneumothorax usually occurs in patients, young elderly patients. There may be a bleb in the pleura which has ruptured, and this can lead to pneumothorax. Now you see in spontaneous pneumothorax, what happens? Can you see these are the blebs? So pulmonary blebs, these are the blebs. Sometimes what happens due to rupture of these blebs, air can enter into the pleural cavity and can result in primary spontaneous pneumothorax. This is again an X-ray showing pneumothorax. Can you appreciate? This is the lung border, and this is air in the pleural cavity. So this is again a case of pneumothorax. Now let us try to rule out other options. Myocardial infarction. Patients of myocardial infarction will have chest pain radiating to back or radiating to the jaw or the left upper limb. But in this clinical scenario, no such history is given. Again, cough is not a feature of myocardial infarction. So you can rule out this option. Now, panic attack, patients of panic attack, they are more fearful, clear? Now, they are anxious patients, anxiety patients, and during the attacks, they develop breathlessness. But after taking deep breaths, there is resolution of that panic attack. Now, in this case, no such history is given. You can rule out panic attacks also. Okay. Musculoskeletal pain will present with a dull, aching type of pain in the muscles. It will have no association with the cough. It will have no association with the chest breathlessness or sweating. So this is again ruled out. So the correct answer will be pneumothorax. Which type of pneumothorax? Primary spontaneous pneumothorax.